Good morning, everybody. I'm Catherine Bianco, a maternal fetal medicine specialist at Stanford University. I work on the Department of Obstetrics and Gynecology under the Division of Maternal Fetal Medicine and Medical Genetics. I am very excited to be here as I'm very passionate about the topic that we're going to be discussing. I had many opportunities and interactions and work in the Periviability Task Force for Stanford Children's with our partners in neonatology and maternal fetal medicine. I have no disclosure other than I'm an MFN geneticist, and my talk might reflect that. So the objectives that we're going to have today, we want to understand the current neonatal outcomes data for mortality and morbidity at this very early preterm gestational age. We'll revise and go over the current trends of clinical management in perinatal medicine with regards to be born too soon. And also we want to touch on what it means to not only be periviable, but have comorbidities as a pre-labor rupture of membrane, fetal growth restriction, small gestational age, understanding the powerful approach of a multidisciplinary team that can really understand what it means for this mother and this baby to be born too soon. So if we think about a clear biological determination of viability, we need to go back to really our embryology times and really think about it. There is a requirement of minimal pulmonary development to really decrease mortality in these tiny babies. And then when we think about morbidity, it's more related to the ability for the development and maturity of the brain. Going back to very classic embryology, if you really look into this slide, and the canicular phase is really what we're going to be talking about in this specific fetal life between 16 to 24 weeks. And it's so important to understand that embryologically, this period is fundamental because it's in the moment that the embryo, the fetal life, as the last generation, the long peripheral the epithelial differentiation is happening, and most important, the air-blood barrier is formed. With regard to the brain development, we also need every single week of this fetal life for not only developing the lobe and the sulcation, but the deep development of the intrinsic network that guarantee a full development of the central nervous system. So about 10 years ago, the NIH had a consensus with a phenomenal team, the Society of Maternal Fetal Medicine, the American College of Obstetrics and Gynecology, and the American Academy of Pediatrics. This workshop was looking to address how to manage and counsel this issue for periviability, starting from 20 weeks and 0 days to 25 weeks and 6 days. And look at the rate of neonatal survival, but also looking at the rate of neurodevelopment disability among those survivors. So after this consensus, a lot of information was available to digest, but we did understand that there are variability between centers of care determined by the obstetric team and by the neonatal management practice. So fast forward many years, these are what we sort of catching up on time since that concept came alive. What is the role of using antenatal testing in this periviable pregnancy? So a very recent systematic review and meta-analysis looked over 31 retrospective observational studies, included over 2,000 infants looking in this specific periviability week of 22 and 0 to 22 and 6 weeks. They reported survivals with exposure on steroids versus not exposure on steroids, which you could see here, we're seeing a 39% versus 90.5%. It's statistically significant. But moreover, one of those meta-analysis was a multi-center observational cohort study that also contributed to this data significant, as they look at more than 1,000 live births between 22 weeks and 22 and 6 days. looking at the exposure of steroids and the postnatal life support versus postnatal life support alone without a steroid. And again, the numbers were a significant showing and a just relative risk of 2.1. So survival without major morbidity was also addressed in this multicenter observation cohort. And those that received steroids had increased survival. We're talking about single digits, so just take it as a grain of salt. 4.4% to 1% survival with no major disability. So these studies and data really prompted the American College of OBGYN to hire a policy advisor and revise it, where you can see in this table, looking at the exposure of antenatal corticosteroids at 22 weeks and 0 to 22 weeks and 6, considering not recommended, but a considered. This is also been reaffirmed after in 2022. And the evidence is that 2C really means that it's weak recommendation and low quality evidence. So take it with a grain of salt. No change whatsoever between the 20 weeks to 21 and 6 days period. Other studies joined talking about associations with antenatal steroids and this tiny gestational age between 21 to 22 weeks. Here was reported by the Neonatal Research Network, as sponsored by the NICHD. They have the ability to look at 431 infants that were, again, living this, born in this periviable stage. 17 of these infants were exposed to antenatal steroids as early as 21 weeks and 2 days, and 304 infants were exposed at 22 weeks. So this data was important to see, as you can see in this table, that they were able to look into, do these neonates were exposed antenatally to a single dose, a full course of steroids, as you know, is 2 doses in 24 hours each to consider a full course, and then the non-exposure. And in the table to the left, you can see how the survival to hospital discharge was increased with those that receive a complete dose. And then to the right, you see the morbidity as compared when it was exposed to steroids as well. So it's the same trend. With regard to other interventions that are done to in the maternal compartment, magnesium sulfate for neuroprotection of the neonate is also an intervention that we're doing currently in less than 32 weeks. But this specific study that was published in Obstetrics and Gynecology looked at an association of the improvement of survival in these extreme premature babies if they were exposed to magnesium, but also if they were exposed to antenatal steroids, and the comparison of being either or none of these interventions. So the idea was, or the hypothesis was to see what would be the rate of severe neurodevelopment impairment or death in this group that was exposed to this intervention. It was a prospective observational study, look between 22 weeks and 0 days to 26 weeks and 6 days. And it was between 2011 and 2014, again, part of the NICHD Neonatal Research Network. The primary outcome was to look at severe NDI or death after postnatal period of 18 to 26 months, corrected age of birth. And secondary outcomes were components of severe NDI. What we learned from this data was the pen of the exposure for the whole cohort show up here in the red table. When they were exposed to antenatal corticosteroid and magnesium sulfate, these previable babies did better with regard to neurodevelopment outcomes. However, when we zoom all the way down to these periviable weeks, the 22 weeks to 24 weeks, it wasn't statistically significant. The author went to elaborate that it could have been a problem with the sample size, since we, single digits representation, but also this particular group had a lower socioeconomic demographic, and mothers were have less than high school education. And so the thought of some access to care and healthcare disparity could have modified this as well. What other things we look at maternal compartment when we are trying to improve outcomes in this periviable pregnancy? is the role of antibiotics. So back in 2000, the ECOG and Practice Bulletin observed this and actually put recommendations up saying that really the antibiotics role was not there really to be supported. However, for pre-labor rupture environments as early as 20 weeks and 0 days, it could be considered for latency, but no GVS prophylaxis or anything like that. No autocolysis, no magnesium sulfate, no steroids. With regard to cesarean section, this is one of the things that we really need to take a minute and really dissect off the data available to us. And the reason why is that you can understand we exposing a mother to a surgical procedure that is not without risk. And it could jeopardize the future fertility of this, as many complications can happen. But so let's see what does the evidence show. So what we worry is like these little periviable infants, most likely they will have more increased risk for fetal distress and intolerance to labor. They can have breech presentation as well, and it will be also determined by why is the status of the mother when she presents to labor and delivery. We already seen early signs of distress, infections, hypertension, and other complications. So Dr. Altman from Vanderbilt published in Obstetric Gynecology the incidence of cesarean section in this periviable cohort. And she also pointed out, as you can see in this table in red color, how the rate of classical C-section was increased. And what that means, it means that really when we commit a mother with a classical C-section, we know that she's not allowed to have a trial labor. She will always need a C-section. But moreover, we could not get, she's 40 weeks of gestation. We have to do the repeat C-section by 37 weeks due to the fact that increase of risk for rupture of the uterus and catastrophic, outcomes for maternal death and fetal death. So it does imply consequence for future fertility as well. So older studies coded here, and one that I want to go over is this French study where it looked at serious maternal morbidity independent associated with the lower gestational age, meaning looking at severe maternal morbidity with they address admission to the ICU, needing for blood transfusion, increased infection and injury to organs. And they also went ahead to address the risk for future uterine rupture compared to prior term delivery. And they definitely had an overhead ratio of 4.9 versus a 4.7, depending on the surgery that the mother had experienced. And they looked at also the risk to develop placental abnormalities. As you know, we have in the raising a placenta creta spectrum that carries increased maternal morbidity and mortality. But also they looked at placenta previa risk. There was an increase of 5.32 relative risk. Same for basa previa, where the vessels, the fetal vessels are actually covering the cervical os, becoming an emergency if we have any degree of vaginal bleeding, and also velamentous cord. So all those implications were reported as a consideration of periviability preterm birth with cesarean section. Moreover, other studies published in American Journal of OBGYN in 2021 look at this population-based cohort to resuscitated live birth babies from 22 weeks to 23 and 6 in the United States. The primary outcome was to see survival to 1 year, depending on the route of delivery. We're talking about cesarean section versus vaginal birth in this periviable gestation. And as you can see, the resuscitated infant delivered by cesarean section, regardless of fetal presentation, vertex, or bridge, or malpresentation, had a higher rates of survival around 1 year of life as compared to a vaginal delivery. Which is, let's pause here and think about this. So which means that these very preterm babies might benefit from an operative delivery. But when they looked at the survivor passing 24 hours of life, really vertex neonates did not show a benefit to being born by a C-section. The data expressed here. So in general, what they concluded was cesarean delivery at 22 to 23 weeks was associated with an increased risk for compositive adverse maternal outcome, meaning blood transfusion, unplanned operation, unplanned hysterectomy, maternal ICU admission. So I'm just trying to relate the story about all these different studies are trying to convey what is the risk for the mother and what is the risk for the baby, and where, if we will, can have a consensus of what would be the best way to approach these tiny babies. Another study, recent study, looked at the impact of motor delivery again in this gestational age from 22 weeks to 25 weeks. It was a retrospective study. It looked primarily composite. They decided to look more as a composite outcome: death, ICU admission, sepsis, surgical site inception, unplanned operation, and maternal readmission. And a secondary outcome was looking at maternal blood loss, the length of stay, neonatal survival, and the complications in the neonatal period as a bronchopulmonary dysplasia, intraventricular hemorrhage, necrotizing enterocolitis, patent ductus arteriosus, and retinopathy of prematurity, ROP. So as a primary outcome, they were trend towards an increase in mortality, but not significant. And a secondary outcome using this compositive, they did see there was no difference between the group depending on the mode of delivery, which is important. So overall, they conclude that perivariable birth was associated with high mortality, maternal morbidity, 19%, and even higher if a cesarean was performed, 23%. There was an intention to treat a study just recently published by AJOC and MFM that wanted to understand the use of pharmacologic information for women based on gestational age by the week of admission. So here you can see that they looked at, again, this gestational age that we've been talking about, but also the rate of intervention. Do they receive at least one dose of steroids? Do they receive magnesium sulfate for neuroprophylaxis? Were they exposed to antibiotics for GBS prophylaxis? What was the role of tocolysis? And on that, they looked at how many of those attended birth were having a plan for resuscitation, and how many of those were delivered at 22 weeks, 23 weeks, and 24 weeks. The majority of the 22 weeks deliveries were vaginal, about 90%. So about a sample of 412 newborn infants had a planned resuscitation, meaning that they will be having active resuscitation. And they looked at this as a 5 obstetrical intervention and 4 neonatal factors. So the 5 obstetrical interventions, what we have been talking about: the role of antenatal steroids, the role of magnesium sulfate for neuroprotection, tocolysis, and antibiotic prophylactic for GVS, and the role of an operative delivery such as cesarean section, and address it with factors from the neonate that we know modify the outcome, such as gestational age, the birth weight, the sex of the infant, and if it's a single gestation versus a multiple. So the odds, so these 3 variables, steroid, gestational age, and birth weight, were significant, affecting the outcomes. And the odds of survival in the NICU discharge was 2 times 0.6 higher than those that receive antenatal states. Significant too for the time and the weight of delivery. But in not enough patients, unfortunately, that you can imagine, to see in these periviable particular 22 weeks to be independent. So it was all lumped up. So although there wasn't enough evidence to really do this 5OB intervention, some patients did receive this intervention and did show improvement of survival. So again, we are seeing gray zone data. Most recently, I would say, is just published over the summer. The Society of Maternal Fetal Medicine had this consult series revising the management for periviable and periviable preterm pre-labor rupture of membrane. And what they did in conjunction with family planning, American College of Obstetricians, and replacing the previous recommendations, and I will take you through with regard to this. But here in this pie that they have it as a figure, it's important to see that they were trying to sort of in a comprehensive way to show what is the level of maternal morbidity with regard to the neonatal survival, as you can see here. Their recommendations were based on level of evidence, and where you can see in the table is like number one recommendation as a 1C is we really want to make sure that we have conversation with our patients that are pre-viable and pre-viable rupture of membranes to individualize their consultation for the mother and the fetal risk, and explore and make sure that their consultation includes choices and also the role of expectant management with this condition. They recommended antibiotics for pregnant individuals who chose to have expectant management at 24-week gestation. However, the antibiotics that we have been talking about after rupture membrane starting at 20 weeks to 23 and 6 could be considered. The administration of antenatal corticosteroid and magnesium sulfate is not recommended until a trial of resuscitation in intensive care unit has been discussed with the healthcare team and with the patient. And also, they touch on the serial amnio infusions and amnio patch that are managed that are there, and they can be considered if the patients are enrolled under a clinical trial, but not as a standard of care. Other things to consider is the situations where mothers actually have a procedure called clash that has been done to prevent the delivery of preterm birth in either for history of preterm birth or for cervical insufficiency, and they go ahead and have a rupture of prematurity of the membranes. So they will be an individualized case scenario because we could consider leaving the cerclage in place if there is signs of infection or distress for the mother, or we could remove it if we think it would be best for the management. And this will be an individualized case-by-case basis. They recommend as well that this history will be included in the future history of the patient as an obstetrical age history and should be considered as somebody that had a preterm birth, as we do for the protocol for preterm birth. I want to take the opportunity to share what we do at Stanford Children's Hospital as a policy. This policy has been developed through our Periviability task force that we have in conjunction with our neonatology team and the maternal fetal and obstetric team, and where we have sort of trying to adopt guidance for when we have a periviable case in our unit or for consultation. So if you see 22 weeks with 0 day to 22 weeks to 6 days, the neonatal assessment for resuscitation can be supported by our neonatologists, but not compulsory. With regard to antenatal steroids, I think with the data has showed you, you could agree that could be considered. With regard to maternal interventions such as tocolysis, antibiotics for GBS, magnesium for neuroprotection, fetal monitoring during labor, and cesarean for fetal indication is not recommended. And one thing that you could consider is to do antibiotics for latency, as I have shown you in the data. When we move a week forward, 23 weeks, 0 days to 23 weeks and 6 days, we definitely had changed our lingo to consider all these options. When we reach 24 weeks to 6 weeks and 6 days, you can see we will encourage neonatal assessment, but not compulsory, and we will recommend all the maternal interventions, but stopping and consider monitoring fetal monitoring in labor and cesarean section. After 25 weeks, we pretty much do usual OB care and trial of intensive care units, only poor prognosis. So this will be, we're talking about not just a small for gestational age or fetal growth restriction, but also rupture and other comorbidities. So not just to be very viable. With regard to sorry. Okay. One thing that I want to touch on very quickly is when we are in the threaded delivery of extraordinary preterm gestation age, but we have the evidence of fetal growth restriction. So that it will be fronting the question is like, at what gestational age the fetal benefit justify obstetric intervention, and at what fetal weight does fetal benefit justify obstetric maternal risk? And so it's a complicated question. So putting here, thinking about 1980s and early 2000, babies under 500 grams will not survive or have minimal surviving. And that's how we've been evolving with medical intervention and active resuscitation. The CPQCC had an extensive publication that highlight babies being born between 300 grams to 500 grams achieve up to 21% of survival to discharge. And that was associated with exposure to antenatal steroids, cesarean section, higher gestational age, and single to birth. And that's brought to the current stage where we can see that has presented by the Neonatal Research Network, where babies under 400 grams can survive up to 12.57% and have survival to discharge with active treatment 25%, so double. I want to just highlight a couple of those landmark papers. As you can see in JAMA Pediatrics, the group published what was the outcome for extreme prematurity in less than 400 grams. These babies were between 22 to 26 weeks, and they received active treatment. They looked at primary outcome for discharge to home or 1 year of life in the hospital, and that's a secondary NDA or survival to discharge. Interestingly, we had almost 10,000 participants, but really down to 400 grams were 220 infants. And those infants were divided on those that did not have any major abnormalities or birth defect. The vast majority were singleton, the vast majority were small for gestational age. So about 100 received active treatment, and about 26 survived to discharge or being in a hospital at first year of life. And 19 of them had a complete follow-up. So you can see we started from 10,000 all the way to 19 cases. So I want you to take this with a grain of salt, but this is the information that we have available. And so infants that would receive active treatment were about 100 of them, and depending on the weight were here listed. As you can see, 90% or more of them were small for gestational age. A lot of them receiving antenatal steroids, maternal antibiotics, magnesium sulfate, and cesarean delivery. And some of them also went ahead and had fetal heart tracing monitoring. So the multivariable model took into account all those different variables I'm talking to you. So I will skip some of this data just to take you through a point that is very important to us to discuss that our counseling team. So as you understand, with the maternal component and the neonatal component, we need to act as a multidisciplinary team. We need to have neonatology, social work, nursing ancillary support, and maternal fetal medicine, even anesthesia when we have these very hard conversations. We use pictorials, as you can see here, where you can see like the hands of an adult compared with a tiny baby, and here showing survival and long-term in different colors. So if you have 100 babies at 22 weeks, only 2 to 9% of them will survive, and you see how they've been colored here, and so on and so forth. Other sources like the British Association for Prenatal Medicine also have pictorials that help for the parents to grasp this very complicated information. Allow for your parents and your family or the pregnant person going through this process and understand what is happening and how a trial of intensive care unit can be considered, but it doesn't mean that it's not reversible. So depending on the imminence of the delivery, allow time for the patient to be reflected and internal discussion with the family or the support system that she has, emphasize the ability for the team for further question and come back and revise. I want to highlight some parents wrote an editorial, which is important to also understand the other side, that is this parental impression when we do the consultation. They say we have zero concern about policy statement based on gestational age and how these babies at 22 weeks can survive while others can die at 26 weeks. So these parents wanted to state that if you say 15% survival, meaning that some babies will survive. They also alluded to the fact that they would like to hear what happened after they survive and not the laundry list of exhausting list of abnormal things that are going to happen to the baby if he survives. So with regard to more considerations, families might have different priorities and value systems. So the goals, the values needs to be clear for this discussion. So definition of the quality of life, perception about impact of disability. Also, the data we handle is different decision and it's the same data, and that's okay. So we need to be also very aware of our intrinsic bias and our personal bias to not be imposed into this family counseling. So closing thoughts, when we approach this extraordinary preterm birth, we want to communicate that words do matter, and our English language is tonal. So how do you say matters, and verbal and nonverbal communications also matter. So remember too that a decision for intervention for a trial of active intervention can be always redirected, and comfort care is care. The babies will receive care even though it's called comfort care. With that, I want to say thank you. It's been wonderful to be here. Look into the Q&A session. And I want to acknowledge the role of Dr. Davis, Dr. Susan Hintz, and Dr. Kathleen Manner in our Periviability Task Force.